Right, well, welcome everybody to Report Out. It's great to see you all. I think really important that we celebrate and understand the great work that everybody's doing to push forward the Leeds Improvement Method, which is our management method, and really does, anyway, for me anyway, it's one of our USPs and really distinguishes us from other organisations in how we sort of engage in improvement for patients. So I'm really looking forward to hearing about the great work that colleagues have been doing, and I'm just fumbling with the agenda. Who is on first? Let me just have a little look. Can we welcome Daniel Park who's going to tell us about using social media to improve access to library services by doctors in training and medical students. Okay, so it looks like you've got 5 minutes. All right, so rapid fire.
Thank you very much indeed, Simon. Well, of course, one of the main challenges for me is rolling out the Leeds Improvement Method when you're not in Leeds. As you know, I'm representing Harrogate and District NHS Foundation Trust today, and I will tell you all about that a little bit later. So next slide, please. The main problem that we have is that medical students and doctors in training are the bread and butter of medical education. Doesn't matter which trust you're in, it's all the same. But it was very difficult to see whether our library service was actually doing anything. We'd got some statistics on borrowing of examination books, but it has to be said that most of the medical students and doctors in training that go to Harrogate do so at the very beginning when they're not going through these exams, which would be much easier if I asked at Leeds Teaching Hospitals. Unfortunately, I'm not at Leeds Teaching Hospitals, so I had to find another way. So how did I deal with this? Well, I went through a plan, do, study, act cycle. Originally agree on the numbers of people actually using the physical library, because as I can see, the medical students and the doctors in training were actually coming in and sitting down and just using it as a place to be. But I needed to measure that. I then needed to publicize that library, and I thought using social media would be a good idea for the kids, you see, because what if a self-respecting young person doesn't use it? Study the effectiveness and then consider what future cycles there could be as a result. Next slide, please. Now, originally, I fell into a lot of mental valleys, and I was talking to Jimmy, and because Jimmy was my coach in all of this, and Jimmy gave me a good slap round the chops because I was sort of having a good cry to myself, thinking to myself, how on earth can I record anything like this? For a start, I tried to look at how communication was, and I created one of these spaghetti diagrams to see how communication happened within the hospital library. The problem with that, as far as I was thinking, was everything's electronic, so it wouldn't really work. How wrong I was, but I will come back to you on that one later. The second mental valley I had was, well, how do I know? How does it possibly know what a medical student, what a doctor in training looks like? I mean, it doesn't really work like that. Then I haven't got doctor in training and medical students stamped on the foreheads. So how am I going to find out? Now, to do that, originally I thought, well, I'll do an observation. And I asked my library assistant to ask people whether they were medical students and doctors in training as they came through the door. The problem with that was that she had to chase them around the library because they had a habit of avoiding her. And then she had to sort of pin them down. And sometimes I asked, well, why are you asking me this question? And then she had to go through it. It was taking her an inordinate amount of time. And that was waste. I know the Leeds Improvement Method is about reducing waste. So instead, we looked at another option, which was to have a sign, which you can see on the right-hand side, with lots and lots of cherubs and things attracting people, and that worked much better because people could not only see it and put the things down themselves, but also when we weren't working out of hours, because the libraries are open 24/7 here, people could still note themselves down. Okay, those are a couple of examples of the social media posts that we've done. So if you look at the outcome, next slide, please. Originally, I had an outcome of a 20% increase. Actually, that went to a 44% increase, which was very, very pleasing after the period of time that I carried out. So I did this, recorded, found out how many people were using it for 2 weeks, then carried out the social media for 4 weeks, and then 2 weeks after that, there was another recording of how many people were actually using it. So next slide, please. What went well? Well, the data collection, obviously, because that helped me to overcome my mental valleys of how on earth am I going to find out who these people are. The mistake checking worked quite well because obviously I had to write of all these social media things. I undertook what is known as a level 3 self-inspection with judgment, but I then added a level 4 successive check by having a percentage of my posts double checked by the staff. Also, of course, technology played a helpful part. And at this point, I'd like to help thank somebody who doesn't get thanked very much, Mark Zuckerberg, because owning Meta means that your Facebook and your Instagram things are duplicated, so you don't end up repeating things and making a mistake in between the two. So the automation was very, very helpful that way. So thank you, Mr. Zuckerberg. Now, there were some unexpected bonuses as well, and that was the spaghetti diagram I mentioned very briefly. Essentially, I did a spaghetti diagram of where things were going, and everything was going out electronically until I got to the point when I actually looked about how staff talk to each other. And we have staff at the issue desk, and then they have me sitting in the librarian's office, and that is a good 6 meters away. And they were coming to me, and I was going to them, and they were coming to me, and I was going to them when I was sending emails. And that was such a waste. So as a result, I'm now moving to sit at the issue desk with everybody else, and it's saving so much time. So that was quite unexpected. What would I do differently? That's the next slide. Thank you very much. Unfortunately, there was one big problem, one big elephant in the room with all of this, and that was that the library was under refurbishment while I was carrying it out. And I was fearful that the fact the library was looking better was attracting people in the first place. What I did to try and avoid that was that the major thing that was going to attract them, the Health and Wellbeing Centre launch, I put that back, and it actually happened 2 days ago. So that it happened it happened after I actually did all of this project. But, you know, as Eleanor Roosevelt said, do the best with what you can where you are. It wasn't perfect. If I could, I would do that. The other thing would be that, unfortunately, I'm moving trust. So next week I moved to Rotherham NHS Foundation Trust after 10 months here. So it's rather difficult to replicate things and carry out under the PDCA cycle when I'm working somewhere else. I would like to make one final thank you, though, to the LIM team for actually allowing me to attend despite my moving trusts. I really would not be where I am today, sitting here as a library manager, without the mentoring of the team in general and of Jimmy Parvin in particular during my 8 years at Leeds Teaching Hospitals. Thank you very much indeed for your time.
Well, that's fabulous. Thanks a lot. Lots of great learning there. We've got time for questions at the end when we've seen everybody's presentation. So we'll move now on then to electronic pre-assessment model. Michelle, take it away.
Thank you. Okay, so yeah, my project was looking at bringing in a electronic pre-assessment model in paediatrics. So what we wanted to do is have a look and see how the pre-assessment process could be more efficient in paediatrics. And some of this came about because there was some new national guidelines for anaesthetics, in that any child now that is going to have a general anaesthetic needs to have a pre-assessment, whereas beforehand it was a little bit of depends what procedure they were having. If they were having a scan, for example, an MRI or a CT under general anaesthetic, that wouldn't necessarily implement a pre-assessment for that patient. We also wanted to go paper light. So what was happening at the time, this has changed slightly now because some things have come electronic in the meantime, but there was 3 paper documents that were being used for every patient. So obviously we wanted to try and reduce that waste. But there was no standard documentation for pre-assessment. So the documents that were being completed were documents that are just needed for admission on the ward on the day. So there wasn't anything specific to pre-assessment. So looking at anaesthetic issues in the past, previous surgeries, that kind of thing. And there's no standard procedure as well. So that's what we wanted to look at. Next slide, please. So to begin with, we wanted to identify the issues. So I had a timeout day with the pre-assessment nurses, which obviously was there to help engage them in the process of change. And it was to identify the issues. So they obviously could identify what issues that they were encountering, and that they could also put their views forward as to what they wanted to change. And obviously most of them did say that they wanted some kind of electronic process to make it more efficient. So I liaised with lots of people from the MDT. So we've got admin staff that are involved in the process, anaesthetists, clinical nurse specialists, the pre-assessment nurses. I also visited the adult pre-assessment team because they've already gone to an electronic model. So that happened during COVID, and it works very well. So although there are some slight differences in paediatrics because we need to ask different questions, for example, what we wanted is the procedure to sort of mirror what they're doing in adults, really. We conducted a process flow mapping exercise with all of the teams involved, which shows that there's a lot of overlapping and lots of things that are going backwards and forwards between different teams. It wasn't very efficient what was happening now, and there's lots of different aspects and elements of the current process. Also gathered some data, so how many pre-assessments were we managing to accomplish every week versus how many now with the new national guidelines, how many we were expected to need to do. So they were only doing about 50 approximately a week, and we estimate that actually we need to do about 170 a week. We also did a bit of a stakeholder analysis just to see who was the main sort of people that needed to be involved and what their stake was in the process. And then we identified what we wanted the new process to be. So basically what we would like to happen is that the patient is identified from an electronic method to say that they will need a pre-assessment. The bots, lovely robot thingy Rob is in the background, will send out a questionnaire to the family. The family would fill out that questionnaire and then they would send that back, which automatically gets uploaded to PPM by the bots. And this is when your pre-assessment team would then get involved from that point. So they would review the questionnaire and start completing a document on PPM. They would triage that to see how long the patient will need for an actual pre-assessment. So that could be 15 minutes to 45 minutes. And then from there, an appointment will be made and the pre-assessment actually takes place, and then the rest of that document is completed. So that's what we're hoping will happen. Next slide, please. So where we're up to at the moment. So obviously this is a big project, so we were expecting to have this complete within a couple of months. This has been going on about 6 months at the moment. So we're currently in a trial period where we're trying a paper copy of the questionnaire. And that is to make sure that we're asking the right questions really, and that the families find them easy enough to complete. And then we're gathering feedback from the parents, carers. You know, how long did it take to complete? Was it easy? Were we asking the right questions? We also need to then gather feedback from staff. So once these questionnaires come back, we haven't actually had any come back yet, and pre-assessments have been done with these questionnaires, but the feedback from the staff, how easy did they find it with actually already having that information there provided by the families, so that you only need to clarify you know, the answers. We're in the middle of developing electronic tools, so obviously we need to work out the system with the bots. We need to sort out the electronic booking form, which highlights the patients that need their pre-assessment. And we're also looking at the sort of medical form on PPM, which is where the nurses will go over the questionnaire that's been done and fill that in. And then we want to develop an SOP. And the overall aim is that we'll be able to do the 170 pre-assessments per week and capture everybody that we need to. Next slide, please. So what went well? So we've had great engagement for the teams. I mean, the first meeting we had, I think we had about 35 people in this meeting. So it was a lot more popular than I was expecting. And utilising the adult teams to understand their challenges, because obviously they've already gone through this process, so they've already got learning from it, and we've been able to learn from their teams as to what went well, what didn't, and what things that they would recommend. And next slide, please. So what would you do differently? So one of the things is the mapping process that we did it via Teams because there were so many people involved, and so realistically we couldn't get a room to have 35 people in. So we did do it electronically, but I think what was difficult about that is then everybody couldn't understand everybody else's involvement, and I don't think everyone could really see what everybody else was doing. So I think in future that would definitely be better done in person. But the end result is obviously to have a successful electronic pre-assessment model that works well in practice. I think, is that the last slide? I'm not sure. Yes, lovely. That's just me. Thank you.
Marvellous. Well, thanks a lot, Michelle. And then we'll do questions at the end, but that was really great. Okay. The 60-day update on the psychology improvement event. So fire away.
Thank you, Simon. So hi, everyone. I'm Lauren, and I'm covering maternity leave for the business manager of psychology. So back in March, I ran an improvement event. I'm not going to call it an RPIW because I did things a little bit differently. So using the skills and tools that I did get from KPO, we decided that we needed to do an improvement week in psychology just to look at some issues that we kind of knew was going on and just wanted to try and work things a little different. So I used some things that we would normally do from an RPIW. We did a 5-day event. I used some of the lean tools and used the Monday to do some teaching, but I didn't stick to the standard agenda from Rapid Process Improvement Weeks, just because from working in the area, I kind of knew what tools would be really beneficial for the clinicians that week in order to start looking at improving some of the processes. So I did the waste exercise with them. We concentrated really a lot on the process mapping on Monday. So if you just move to the next slide, please. So as you can see here, all the pinks, the light pinks and the dark pink, because we ran out, are waste that we currently had in the process. So we just started from when a patient is first referred into our service to when they get their first appointment. So in psychology, it's split across medical, neuro and surgical. And we noticed that we was maybe lacking some standards across the processes. We was, due to COVID and just things like that, we'd started to kind of work a little bit differently. And that's what a lot of our waste actually showed when we did the mapping together, just the different routes of how we do things, different documents, different systems. So throughout this week, we decided to work on removing as many of them pinks as possible that we could by the Friday. And due to my relentless nagging throughout the week, I'm sure my team will say we got a lot of ideas, which were absolutely amazing. And I'll quickly talk through some of the quick wins that we had in the week to remove a lot of them pinks. So if you go to the next slide, please. So one of the biggest things, which may not sound massive, but that was we had no standards with, was opt-in letters that we sent to our patients. So we noticed that we actually had 2 different systems from which our opt-in letters were going from, which was ePro and PAS. And we also found about 7 different types of opt-in letters that we were sending. So I'm not sure if you're all aware, but we actually have standard opt-in letters that are built into PAS that is a lot quicker and a lot easier and is a standard. But after speaking to the team, we realised that the reason that we wasn't all using this standard opt-in letter is we didn't think that the words was really friendly enough, is a word that some of the team used, and it didn't have all the information that we wanted our patients to have. So in order to get everyone to kind of agree to that, moving to that one standard opt-in on PAS, we realised that we needed the missing information didn't all need to be on loads of bespoke letters. We just needed to actually update our website, change the wording a little bit, and ask obviously that if patients need any extra information to direct them to our website. So not only did we rewrite this letter and get this changed throughout the week, we also got the department, you know, everyone were really helpful to update their website as well, so that by the time it got to the end of the week, we could be happily sending patients to the website and knowing that it was up to date. Next slide, please. So we also did some 5Sing as well. I had one member of the team that loved this tool more than anyone because she just loves to organise and clean things. But when she started looking at the X Drive, I think she maybe regretted that a little bit. So we started a reg tag sale of our X Drive. So our X Drive is like the G Drive, but it's just something that we all use as clinicians. But we kind of noticed that we had the same documents or documents that hadn't been used, and it had become a place that was just daunting and scary, to be honest. If someone said, oh, it's in the X Drive, you knew it was going to maybe take a while to find. So one of the projects that we started during this week was Lauren, who is in the call, started doing some reg tagging, going through documents that they knew wasn't used anymore or they thought wasn't used, any old documents or duplicated, and we sent out an email, you know, just to ensure that everyone had chance to have a look at that. And that's something that's obviously continuing because it's a massive job. We also did the stationery cupboard, and I think, yeah, one of the best lines, and I've put it on here, during the week when we was 5S in the stationery cupboard, someone said, I didn't even know we had one because it wasn't a very obvious stationery cupboard. So I thought I had pictures, but I don't, so apologies. But it's now everything has a place where it's meant to be. We know what we need to order. It's all labelled up and everything. So we actually now have a stationery cupboard. So that's great. Next slide, please. Another quick win that we also looked at were different visual controls. So one of the things we talked about, and I've cut it off one of the photos, so apologies, but if you look at the ones with the names on, that is our fire safety board. And another thing that kind of came out is when new people start, there isn't always the same. There wasn't a standard checklist of maybe everything that was covered, so not everyone was aware. But we use this board in case there is a fire. So if your name is purple, you are in the building, and we know, you know, not to run out and leave you. If it's red, obviously you're not in the building. But not everyone was using this because not everyone actually goes out past the fireboard. So we decided, as you can see, to put some signs on all of our exits just to make sure everyone goes back and does this. We also did some work around how easy it was to find the building and signs, because we do have patients who struggle quite a lot, which can take up quite a bit of the admin time, having to direct them over the phone. I've had occasions where my teams had to actually go find patients, you know, stuck. So one of the clinicians from the week took the action to liaise with site, with estates and facility, and talk about signage and things like that as well. Next slide, please. So I'm stuck for time, so I'm not going to go through all of these, but these were just some of the other things that we focused on in the RPIW, in the improvement week. We also have our own improvement board as well, where you can see all these. So just some quick things. We moved everyone over to Attend Anywhere. So we were originally paying for Zoom licenses, realized that, you know, Attend Anywhere that wasn't maybe suitable prior has really developed and come on with time. So we decided, obviously, it's a free service and it seems to be working quite well. We also decided to go back to ensuring that we have a standard opt-in process. So all patients will now have 3 weeks, which, you know, is the standard policy, but due to lack of understanding sometimes and lack of knowledge, we was maybe given a little bit longer. We changed a couple of other PAS letters as well, just to sound a bit friendlier and make sure that the patients were pointed to our website. We did a flow chart. So we have a lot of different letters, so I don't have time to go into it, but clinicians wasn't always aware of which letter to be requesting, and that was just generally due to there is thousands. So during that week, we created a flow chart that's really obvious. So if it's for opt-in, for example, please send this letter. If it's for a DNA discharge, please send this letter. We also noticed that how admin are getting requested to do certain tasks can be different from time to time, and it can take quite a while to depict the information. They might have been missing information. So we came up with a standard template of communicating with admin now. So when a request comes into the joint inbox, it's on a standard template that's made sure it's got all the details that are needed. So it just really reduces that back and forth and that wait state in between of, maybe going back to checking for information and then someone being able to get back in time. So that's been able to speed up how quickly we get admin slots filled and things like that. Next slide, please. I'm just really conscious of time. So we did use some of the tools. So we still use the newspaper, which I'm more than happy to share, that's in our X Drive. And we called it Don't Polish the Turd because we realised during the week that that's what we had been doing. And that was from one of the clinicians. Rather than maybe having time to improve it, we was just polishing over it. And that's what ended up getting loads of different standards across the trust. So that's why we called it that. So I'd just like to say thank you. Next slide, please. To the whole team. They were absolutely amazing, honestly. I think trying to do an improvement event in the department that you work whilst doing a full-time business manager role is hard, but I couldn't have asked for a better team to do it. And I don't think she's on this call, but last minute, Natasha Bissett ended up coming to help out on the Monday because I was on my own, and major shout out for that. So thank you.
Well, fabulous. And that is excellent advice in respect of not polishing that thing.
Not polishing the turd, Simon. I'll say it for you.
Yeah, let's not make what is it? Let's not being perfection and being the enemy of the good is the posh way of saying that, isn't it? But that's what I'm right with you there. Okay.
Thank you.
Right, fabulous. Okay, look, we're nearly out of time. I just want to congratulate everybody. Really great work. What I noticed from that was how many times are examples of using the tools that are in the Leeds improvement method, helping our thinking and helping us get to solutions. All right. So I don't think we've got time for anything else other than that. Congratulations. So can everybody put their clapping hands on, please? And let's just give everybody, put your microphones on and give everybody a big round of applause. All right. Come on. 1, 2, 3. All right. Fabulous. Okay. Thanks a lot, everybody. All right, so that's the close report out.